Talked with a few of you, ran into you yesterday evening, and I would say that the common sentiment that I heard that yesterday was a full day, and it was a good day, and that you all were feeling especially jazzed about meeting and connecting with each other face to face, and the folks that you're getting to work with and starting to build some community, and so that's fun to see that starting to spark. And we have another great day in front of us. We're going to do a little bit of a deeper dive and really, continue to explore what does it mean to kind of help create and bring about a more equitable, more inclusive community. We're going to do that in just a little bit, and we have a guest and a friend who's going to do that, at least kick us off with some ideas. And then we're going to find ourselves, after a break, back here as a full cohort and do a little bit of reflection forward, name some next steps. You'll grab a boxed lunch, end up in your respective neighborhoods in your category A's, and have a little bit of time there, and then we'll head home. So that's what the game plan for the day looks like. I think, again, it's going to be another great day. And before I jump in, this says thought of the day. You've been hearing me talk, and so I wanted to kind of bring some folks in our kind of growing community to kind of ground us in a thought of the day, reminding us why we're doing what we're doing. And so two people that either by serendipity or for their lack of fortune ended up bumping into me. So the first I'm going to ask is Jenika Baldwin, who I happen to be standing next to in line with her beautiful son, Zion, to just kind of share a thought or two to kind of kick us off. Welcome.
Good morning. Good morning. Good morning. So I was asked to share what motivates me, and I'll say that I grew up in a culture, a faith-based culture that focused on the 8 laws of health, and I never really took much notice of it until I got older and I realized how much diet and exercise actually affects who we are and how we are. And as I started seeing the effects of it, it started becoming something that I was a champion of. And to come into an opportunity to do it on a larger level is just something that is very inspirational to me. And I'll tell you 2 quick stories, and I'll start off with the positive. A couple of nights ago, we were out, and I was breastfeeding my son, and we were at a restaurant, and a waitress comes up to me. She says, "Were you breastfeeding?" And I said, "Yes." And she said, "Well, thank you." She said, "When I was breastfeeding my son, I got a whole bunch of stares and a whole bunch of grunts from people, and somebody comforted me by paying for my meal to let me know it was okay." And so I would like to pay it forward. And so she paid for my meal, and we have to live the example to let other people know and create a culture of health. And the other story is this morning I woke up and was told that somebody from our community was admitted to the hospital because of heart issues. And it is due to a poor diet. And there's nothing that the doctors can do except for make him comfortable until he passes. And that's the reality that we live in. And we can't stop death, but we can inspire people to live the best life that they can now. And the positive note of that is I'm in a room full of people who have that passion, whether it is the American Heart Association, whether it is the Planning Association, which is helping to get people motivated in exercises. We are a room full of people who have a passion for helping people live their best life now. And so I thank you guys for allowing me to be a part of it, and I encourage you to keep your passion and go into the communities that you're at, because everybody needs to know. We all know it, but to make that step easy to live a healthy life is what we're aiming for. Thank you.
Thank you so much. Beautiful. Thank you, Jenika. So one other person I asked, do you mind coming up here? Chip Johnson. Some of you know Chip. I've run into him the last few years and has inspired kind of what the best in government in many ways has to represent. So Chip, I'll let you take it from there.
Okay. They only gave me 2 minutes, so I may go over. Y'all know me.
Okay. Not too far over.
Okay. So why am I here this morning? I'm the mayor of a small town. I've got 3 fire departments running that I'm in charge of. I've got garbage trucks out. I've got a dog catcher. I've got an ambulance. I got 35 cops. Why am I here when I should be back home running a city? Well, when I first got elected in 2005, they put me on a regional health council because they needed a token elected guy, and I was it. And so they asked me to go speak at the Southern Obesity Conference. I'm like, what in the world is that? I've never heard of it. And so I went, And while I was there giving my little talk, I stayed after and listened. And somebody at that conference in '06, I think, said this may be the first generation of children who don't live to be as old as their parents. And I heard it, and I just kind of thought, that really can't be true. That's just somebody spouting off something. You know, it can't be true. It's so awful. And I went back and researched it, and sure enough, it was true. This generation of children is in trouble. And I felt kind of responsible for that. And like I might have a way to help it, or a way to change it. And so that's become my passion. So when I'm working on childhood obesity prevention, I just kind of accidentally work on health promotion for everybody. If you're trying to make things good for the kids, you accidentally make it good for everybody, right? And so I keep thinking back to what could I do to affect it? So in '07, we became the 7th city in Mississippi, and this is kind of interesting, the first predominantly Republican city in Mississippi to go smoke-free. That was important to me. Both my grandpas, and I had a passion for it. Both my granddaddies died from smoking-induced cancer. Both my grandmothers did not smoke and died of cancer. Is there a correlation? Who knows? What I do know is 540 some odd people in Mississippi die from secondhand smoke every year. That makes me passionate. A good friend of mine had a stroke, a brain bleed stroke, 3 years ago, which was brought on by chronic high blood pressure, which was brought on by morbid obesity over the years. So one day he'll die from a seizure, and they'll just say, well, he died from a seizure. I know he will eventually die because he was morbidly obese. That's what's killing my friend. So how can we affect that? And then I've had another little win. You know, the smoking was my big win. I told the mayor in the city next to me in South Haven, he said, hey, I want to tackle this thing. I said, it's going to be hard, but it's going to be probably the most important thing you ever do in your life. And I still feel like that was the most important thing I've done. But I've got a really good friend who 2 years ago had a baby in the hospital, and she's an engineer, and she wanted to have that baby by the book. And she wanted to breastfeed, and she's been reading the manual. And she had that baby in the Baptist Memorial Hospital in DeSoto County. And they were kind of, after the baby wouldn't feed for about 3 hours, they were wanting to put it on formula. And she's like, no, I want this baby to have my milk. And she had to fight them for it. And so I fought with her. And so now that hospital has an Empower grant, and they are working to become a baby-friendly hospital. 10 weeks ago, she had her second child there, and it was easier because they knew what they were doing. They were teaching her how to breastfeed. Not that she needed to know this time, but they were encouraging the breastfeeding. So those are some things that you can do. You can literally make change. And yes, I need to be back home worrying about catching dogs and paving streets. But every once in a while, we have to regroup and refocus and remember our passion of why we're doing the work. I mean, most of you are here because it's your job. But just sit back for a minute and remember that you do affect people's lives and try to regain your passion. That's what I encourage you to do today.
Thank you. Appreciate it. Thanks, Jenika and Chip. Great way to start our day. So David and I have been kind of reading this book called Love and Power. I'm kind of rereading it. David lost it here at the hotel. We'll find it again. Adam Cahan. And it's kind of based on the premise in this quote and teachings of Martin Luther King, which is this notion that power alone can, without love, can be abusive and reckless. And love without power can be anemic and sentimental, and that we actually need both of those things. And I think what we're talking about doing here in this effort is really fusing love and power. Policy, system, environmental change, but the compassion that you just heard from these two speakers, why we're doing what we're doing is out of love. And, you know, the speaker I'm going to bring up here in a moment, Dr. Shoma Stout, I can't think of a better example. Shoma is the executive lead of something that some of you have heard of, the 100 Million Healthier Lives effort, a global, audacious effort that I think is really putting these powers, these kind of the dualities and power infusing love and power on the behalf of a global citizenry. And so you're going to hear a little bit about that. And Shoma's, again, we're not reading everybody's bios. You can check out, Shoma's got a very impressive list of experiences. He went to Harvard, and she teaches an Innovation Fellows program in primary care, and she was a primary care doc in their safety net at CHA for a number of years, and on, RWJ, a young leader. But what's most impressive about Shoma is who she is what she embodies, her commitment to justice and equity. And it's a great delight to invite my dear colleague, Shoma Stout, to the stage. Please.
And maybe many things, but tall is not one of them. Monty, thank you so much for that kind and wonderful introduction. It's such a pleasure to be with all of you this morning. Because to me, the people who are working at the front lines of our communities, really doing the hard work of figuring out what it takes to create health, well-being, and equity in the world, working together across mayors and mothers to think about what it means to make this a reality, to connect love and power, heart and method together to be able to really ask the question, whose life is getting better because we're here, and to have the courage to answer that for ourselves and to learn when we're not getting the results we are, and to have the courage to change our direction. These are the heroes of this age. And so it is my pleasure and honor to be with all of you today. And I thank you in advance for doing the work you're doing in community. I will not be speaking to you for an hour and 15 minutes. I'll speak a little bit to you, but really I'm interested in you speaking to one another and for us to be in conversation together. So we will hope to have some of that time. I'd like to begin by telling you a little bit about my journey. And, you know, as we've been doing this work and have spent a lot of time in a lot of places thinking about health system transformation, I think one of the things we need to do more is connect our stories to find the person in the population. To recognize that a population is made up of millions, hundreds, thousands of people, real people who are more complex than any one thing that defines them, whether it's their race or their ethnicity or poverty, whether it's heart disease or diabetes or cholesterol. People are made up of with all complex mixes of all of these things. And then to add on top of that, life happens to them. You know, how someone feels on a day that someone said you did great, and on the day that they lost their job, without changing a single thing on that day about your socioeconomic status. Maybe 6 months later that might change, but on that day, people will thrive or not thrive in a very different way. And how can we begin to weave in what it means to understand people as people in our work? That's some of what I hope to share with you today in terms of how we're learning about what that looks like to do that. I'll share with you some of the story of the journey and what it's looked like over the last 20 years of my career, seeing how people have done that and what the outcomes are when people are able to do that, and how communities and health systems all around the country in the US and all around the country around the world are beginning to take on this very different way of approaching the journey to create health, well-being, and equity. And in doing that, recognizing that we are not alone, that we are not powerless, that we are not weak, that together we create an abundant community of solutions that can help each other figure out how to get there, both within any one of our communities and across our global community of people on this journey together. So before I even, I now live in the city of Cambridge. And I first came to the city of Cambridge as a college student. My daughter is just graduating from high school, and she will also be going to school at MIT. She'd never go to Harvard, which is where I ended up. But and I'm so excited to have her back home. She's actually in Wales at the moment, and that's a whole other story, being a young global citizen. But as I came to Harvard, I noticed something very unusual when I got there. Now, when I'd been born in India, in Kolkata, in a family that made about $10 a month. And in India, when you make $10 a month, you are not in abject poverty, but you're perhaps marginally housed. And when you're marginally housed, you generally, there isn't enough power, like electric power. I don't mean like people power, I mean just electric power to go around. And so you lose electricity every night. And so that meant that I spent most evenings in the veranda with my mother, who is a math teacher. So she would ask me a lot of math problems. I'm relatively good at math still. But she'd also say, take a look at the world around you. How many people have so much less than we do? And what it means for so many people to be living in shanty towns, in cardboard boxes or corrugated metal homes. And that we have so many gifts, so many things that other people don't have. And what does it mean? And that if we have gifts, if we have talents, while we have breath, it is our obligation to do something to help. And I think so much about my mother's way of thinking about the world and how that influenced me to think of myself not as someone who was poor, quote unquote, but as somebody who was strong, who had something to give. And I wonder how often in our discourse on poverty, we rarely talk about the importance of building those kinds of mindsets, of thinking of them as important as immunizations, to actually build that resilience, that belief in self, and that belief in possibility. When I got, there's through a long story that I won't go into today, I ended up at Harvard for my undergraduate years. And I found that there were people who were living on the streets again. And up until then, in India, we knew why people were poor. We knew why people lived in the streets. They didn't have money. They'd come from the rural areas into the city, and they didn't have money. But the poverty in India was very different. People were poor altogether, often as a family. No one judged someone because they were poor. In fact, we knew they were poor because they didn't have money. And in fact, people saw it as their obligation to be part of creating, part of helping in some way. And what was even more interesting when you walk down the street in India, and there will be people all in Kolkata, no one when people speak to one another, they speak to each other relationally. So even though someone might be clearly homeless and on the street, if they were to address me, they would address me as sister or daughter, and I would address them as grandfather or uncle or aunt. We saw ourselves as in relationship with one another, but when I saw people on the streets in Cambridge, I realized that it was very different. People walked past. They tried to avoid that eye contact. They didn't know what was happening. I became very interested in this. Now, I thought I was going to be a molecular biologist. In fact, I have a master's in molecular biology. I was running on my way to getting my PhD in becoming a scientist because I was so intrigued by the genomic age. But in the meantime, I was spending my time, as people would ask me for change, I'd ask people, would you have lunch with me? Would you have a meal with me? And share with me your story. And as they did, I learned that poverty here in the US is so different. It's a poverty of stigma, and it's a poverty of social isolation, and it's a poverty of trauma, and from veterans who are actually the largest proportion of people who are homeless in our streets today. And it's a poverty of social connection, where people have failed their social safety nets, and of mental health and addiction issues that accompany that. And in the wealthiest city, outside the wealthiest university in the world, in the wealthiest country in the world, I couldn't believe that there were still people on the streets who seemed so much poorer than the people that were in Kolkata, even though they had more access to food, they had more access to things. And I began to wonder what that meant. And I also began to wonder, I could spend my life doing incredible work in genetics, and I could see that would be so compelling. But there seemed to be this very simple technology called housing that had been invented like a really long time ago that wasn't reaching everybody equitably. And I began to wonder what that meant and what it looked like to learn what it took to create a shift within that. And that really changed. I created a 180 in my professional journey, went over to the Berkeley UCF Joint Medical Program, which is out of the School of Public Health there, and began to learn from communities all over the world in some of the poorest communities. So I did my master's work in Guyana in South America, in the second poorest region of the second poorest country in the Western Hemisphere, with a nonprofit that took a totally different approach to what it meant to create improvement in health, and have had the privilege now of watching that story unfold over 20 years. So in this region, there were 16,000 people across 33,000 square miles. This was a predominantly indigenous community, and they had some of the worst health outcomes in the entire country. They were like the number 2, they had the second poorest health outcomes. And when we looked at why they did, you could cite all kinds of things at the beginning. They had no roads, well, that was a problem. They didn't have a doctor. They had only up to a 5th grade education. And when faced with that kind of stark inequity of basic systems and structures, one wonders, how is it possible to even begin? How do you even begin to help people think about what a journey to health is? But what this organization did that was so remarkable is that they believed that the people within this region had tremendous potential. They described it as nobility, that their voices, their ideas, their contributions were needed in the world, and that the process of development had to be about unlocking the voice, the potential of the people within this region, within this indigenous community, to be able to contribute their solutions to an interconnected world. And that without those solutions, it would be sort of like we were trying to put pieces of a puzzle together and we wouldn't have the whole picture. So it was a sense of needing that to come out. It was a process of accompanying people over time, of teaching methods like improvement, like being able to assess your community, being able to learn, but recognizing and actually planning for sustainability, being that within 10 years they would no longer be needed in the program, and that the people would have taken over the process of development for themselves. And so everything they did in their accompaniment was about building that. It was about partnership across sectors. They didn't even think about it that way. They said, well, what creates health? Well, clearly, health is created across its mental, physical, social, and spiritual well-being, as they put it. And so that needs everyone working together. So their health teams were made up of community health workers, villagers, and teachers, sometimes faith-based leaders, but they were just a team. They weren't a cross-sectoral coalition. They were just a team. And that team looked at what was the need in the community, and they had the courage to learn their way to what was needed. So at the beginning, they began and did things related to healthy food, which was important because it turned out that they didn't have the right vegetables. Like they were farming agrarians, so they had a lot of vegetables and a lot of meat, but they didn't have the right balance of them. So they figured out they used a lot of cassava. So they figured out those kinds of things. And then over time, they took the usual public health things and really figured out how to use arts and dance and things like that to make those come alive. But then realized that up until, as they discovered what to do, these community health workers, villagers, and teachers increasingly got trained up in leadership and in leading their community. And I'll never forget, it was about year 5 that the shift happened where they took over control. And when they did, empowered and confident in the skills to take care of their community, within 1 year, villages had figured out they had eliminated malnutrition among widows and reduced the malaria rate incidence by 90% in 1 year. Within 3 years, they eliminated acquired developmental delay in the entire region. The solutions they came up with were not solutions I or anyone from the outside of that community could have come up with. They figured out that there were widows who could no longer farm, and they didn't have enough to farm to make it over through the winter once their husbands had passed away. It was a 2-person job. And so they would become malnourished. They knew what to do about malaria, but they just couldn't afford the mosquito nets. It was a subsistence economy. So the health team, got the widows to stop farming form a sewing cooperative, and weave mosquito nets for the rest of the village that they exchanged for food. It was such a simple solution. It's not something that anybody who didn't have a relationship with those women, who didn't have trust, would have been able to actually offer or suggest to them from the outside. But because they were leading the process, they were able to create solutions no one of us could have conceived and achieve some of the most dramatic outcome results that I could imagine in health and healthcare. And eventually they did get to those structural features. They realized that if they only had up to a 5th grade education, their health system would forever be led by people outside who would come in for a year. And that was a structural problem with creating solutions. And so their investment in health meant that the entire region put all of their resources together. And I don't just mean their financial resources. Teachers from every school district came and volunteered and began to create a high school. And that investment as a region in a high school with a strong science track meant that within 10 years, they had their own doctors, nurse midwives, health officers, malaria officers. They took those structural barriers and utterly overcame them. But they grew their way into that. They figured out what it meant to have a vision for their community. And because it was their community and their lives and the people that mattered, it created transformative, lasting change that ended up influencing change all around the country and all around the world. I became very interested in whether those principles applied in other places. I feel like most of my career, I owe to what I learned from this one small organization, Varka Foundation, in the way in which they worked with this incredible community of change makers, many of whom had only a 5th grade education. Who having achieved some of the most incredible health outcomes in the world. At Cambridge Health Alliance, where I've had the privilege of being a primary care doctor, how many people here are familiar with Cambridge Health Alliance? So, it's a safety net system that takes care of about 100,000 patients. It's actually up to about 130,000 now. Half the people speak a language other than English. It's at 82% of people are on public insurance, the vast majority of which is Medicaid. So this is truly a safety net system. 3,400 employees in 18 labor unions connected in, yes, anybody got more, please? I keep trying to find the group that has more for such a small, relative small system. What's interesting about Cambridge Health Alliance is we had 12 community health centers, 2 hospitals, so usual healthcare stuff, but also school-based clinics, and we ran the public health department. But at the beginning of our journey, in applying these kinds of principles, we saw ourselves sort of like we were, when you're in an apartment building, and you see the other people who live in your building at the mailbox, and you're friendly with them, and you say hello, but you don't think your fate has anything to do with one another. That's really how we were. We were nice, but we were not collaborative. We didn't see ourselves as interdependent. When Massachusetts healthcare reform happened, all of that had to change. We suddenly got a call from the governor saying that they had expanded coverage to, they didn't quite say this, but they'd expanded coverage to 4 times as many people as predicted, ran out of money, and thought that perhaps defunding the safety net would be a good way to recoup some of that. As they said, let the money follow the patient. That's a whole thing. They actually called to say that the $40 million they owed us this year wasn't going to be coming through, and the $100 million for last year for services already delivered wasn't looking good either. And I don't know about you all, that would have been a death knell for us. Of course, we did the work of helping the state recognize that if you've expanded to coverage to 4 times as many people, you might need some people who would actually see and take care of those people to realize some value. But in that process, we also did something that I think was extraordinary. We went through a visioning process in the midst of all of that drama to say, why should we survive? If we survive to the year 2015, what would make it worthwhile for the people of Massachusetts to have a public safety net system? Whose life is going to get better because we were here? If we can't answer those questions, maybe it's better that we're not here. And so we went on a visioning process to ask and answer those questions. And that moment, I have to tell you, that call was probably, the most important call of our lives, because we changed everything. We said if we truly want to achieve our mission to improve the health of our communities, then we need to focus on our communities. We need to focus on improving health, well-being, and equity. And boy, all the things we need to do to address the social determinants, to focus and invest in primary care and behavioral health, mental health, and addictions, things like that, none of that is funded in the current system. And so we said, let's change the financing system. And that is a huge jump to make, but we literally looked at it and said, nothing we believe actually matters gets paid for or reimbursed. So why are we wedded to the system we have? So over 5 years, we changed from a fee-for-service system where we get paid transactionally for services, and really everything else we did to help people was secondary, and the high-end services got paid. We took what we call global payments, where we got paid for the person, and anything we wanted to do to improve their health and well-being was fair game. And when we did that, for that 100,000 patients, we went from less than 1% covered that way to 60%. I could give you a whole lot of stories about the challenges of doing that, and boy, that scraped elbows and bruised knees, we got along the process. We were able to just begin by understanding who these people were, who the population is, what their context and place was. And by doing that, redesign the system so that within 2 to 2.5 years, when the Commonwealth Fund came and evaluated us, we'd improved the experience of people in our system above the state mean. We'd achieved a dramatic improvement in health outcomes above the national 90th percentile for our completely safety net population, half of whom speak a language other than English as their primary language. But we'd also taken 10% of absolute cost out of the lowest paid healthcare system in the state of Massachusetts, and 15% compared with our comparison group in the state, and been able to reinvest that into what really matters to create health. And we've improved joy and meaning for our workforce in the process because we got back to mission. And that's why everybody was working there. And I share this story, not because I hope you get a call like we did. I don't wish that on anybody, really. But because in that moment where we could have chosen to see ourselves as poor, we chose to see ourselves as strong. And we chose to see ourselves as being asset rich and said, how can we change the system so that it matches mission and our assets, our ways of making a difference. And when we're able to make that shift, it creates new possibilities for what's possible to do. I'll tell you what's interesting is that that side of that changed finance side now is the part that helps make us money and helps make us financially sustainable in the long run. Isn't that funny? And great. But here's the trick. So in Guyana, they also taught you this other thing, which is like where you figure out what you need to do. You do that. You learn how you do what you see the problem is, how you address it, and then you'll figure out what the real problem is. It's like peeling an onion back. And then when you peel that onion back, you see what that next problem is. You then have the obligation to address that. And then you do that, and then you realize what the real problem is, and then you keep going. That's how you create change. So here's the thing. See that blue line? That's our hospitalization rate for people with diabetes. For the safety net system, across our entire population of everybody with diabetes, we were able to get the average A1C level to a 7.1. That's a remarkable outcome. Our hospitalization rate went down by 36%, and it's actually gone down even further since then. But see that red line, that super pesky red line? I felt great about the data until I saw that. That was the number of people who developed prediabetes and diabetes in our population at the exact same time. What are we doing? We realized that if we couldn't address the obesity epidemic, we just had, it was like somebody was pouring gasoline in a fire we were trying to put out all at the same time. And that the context of our communities mattered, of course. Now, you all know this. It took us a little while to say, oh, yes, we had healthy community activities, and we had this health system stuff, but they weren't connected. We weren't building off of each other. So we began strategically building off of each other. And as we began to do that, and for instance, saw that kids were becoming more and more obese. How many of you are working on childhood obesity in this room? We realized that the kids spend once a year with us and every day at school. So we got the schools. We said, we have an asset. What does that look like? And we began partnering. And by fundamentally changing with the schools changing what they were doing by adding school breakfasts and school lunch along with school lunches, but making those culturally appropriate, fun, kid tested, as in terms of the food itself, we were able to reduce the K through 8 obesity rate by 20% compared with our control sites across every child who is going to public school. And I think that's the kind of thing that is only possible to achieve if you realize, where are the kids? Who has the real access? Now, you might wonder, what was in it for the schools? Why did they care? Well, actually, they do care, because if you're, it turns out that obesity is also related to body image issues. It's related to attainment and educational outcomes, and physical exercise is too. There's a school teacher in Scotland that's been able to eliminate overweight and obesity in an entire grade, and now across multiple grades. Her desire to do this wasn't because she cared about obesity. She cared about her children paying attention. And she found out that the 2 times that they had PE a week, by the time they got there, they could barely run. They just weren't physically fit. So she began taking the kids out on a daily mile. And by creating a daily mile, no changing clothes, no locker room stuff, you just go out there and you run a mile in the dirt track outside her school, she eliminated obesity and overweight for entire grades. And this is now scaled up throughout the school and through others. A simple solution, which led to better educational outcomes as well. Here's the thing. You all know these slides. You're at a CDC conference. We're spending $322 billion a year on diabetes. And you saw, and we did best of care efforts to control diabetes. That 36% hospitalization rate reduction, things like that, got our Health and Human Services actually did an evaluation where they said that our transformation was one of 4 innovative and effective transformations in the country. We got awards from Robert Wood Johnson Foundation, right? Except it wasn't enough. Like, not really. Not if you really look at the scope of the problem. I don't mean the awards weren't enough. The awards were great. I mean, in terms of actually improving the health of our community and our population, what we were doing wasn't close to enough. Do you know what that $322 billion is expected to grow to between now and 2020? What would you take a guess? Who said 500? Ding, 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 $500 billion. What would you do with that money? Seriously. That's our money that is being spent on something that is not something that patients value having. Does anybody know a patient who says, yes, give me more diabetes? No? And isn't being used to help with everything else that could be spent on, whether it's housing or transportation or all of the other things that relate to health. But here's what I really began to figure out. That actually that molecular biology training I'd gotten way back when, and that medical training where I knew I'd actually worked on stress hormone receptors, it turns out that the everyday stress of chronic poverty, of racism, of not thriving, and equity is so complex. We've come to, in 100 Million Healthier Lives, just ask the question, who isn't thriving? Then you'll figure out which ethnic group and which race. You can actually just look at your data, see who isn't thriving, and understand the complex interplay of who isn't thriving just within that. When you really look at it, it's really, that comes down in the body to chronic stress. And chronic stress revs up your glucocorticoid hormones, which actually leads you to prediabetes and diabetes. The link between equity and chronic disease isn't theoretical. It's actually what people can check biomarkers for now. And so all these things around housing, around having high demand, low control jobs, around lack of access to social capital, and social isolation and stigma that often accompanies these issues have a direct biologic impact on the body. In fact, when they've done studies, and this has been done at Harvard, looking at blood C-reactive protein levels, which is an indicator of chronic disease, they find that exposure to toxic stress in childhood can lead to a 40-fold higher rate of getting chronic disease by the time someone's 50. 40-fold. Do you know how much all the medicine I can do in primary care with the best, most effective primary care transformation I could make? Not that that isn't important, you have to do that. You know what the overall impact is of all the medicines that I have at my disposal in reducing that rate? Like maybe twofold. Remember all those things that we were talking about? That, 20% reduction in obesity rate? 40-fold. How can we afford, as a country, not to work on equity? Chronic disease is just a manifestation, it's a symptom of the underlying disease. And what's fascinating, if you really look at the genetics and the epigenetics, is we can now look at our DNA and see that the DNA, as people are exposed to chronic stress, gets extra things added to it called methylation bodies. And that you can see that in people's blood when you actually test it and see it. And that methylation that's changed in the DNA, that's an actual biological change, is passed down so that a child born will actually inherit the methylation, the chronic stress of their parents. So this nature versus nurture debate that we perpetually have, it turns out biologically, it's nature and nurture. It's both. And they're constantly intersecting and influencing the other. So even if I just cared about chronic disease and a biological view of the world, it would actually not be possible for me to attain the outcomes I seek from even the biological side without addressing equity. I'm just going to let that sit with you for a moment. Does that make sense to people? Of course, you guys know this practically, right? You guys know it's hard for people to concentrate on taking the right medicine when they're worried about being evicted. We know, in fact, that the drivers of health are at this point only 10% related to what we can do within healthcare. I was looking at all this data and was looking at our health outcomes. Those great outcomes where we had reduced hospitalization rates by 40% for our top 10% chronically ill patients, and by 50% reductions in emergency room visits that gave us that money that we could reinvest to actually create things. And what we saw was that in every one of those cases, what was happening was that people were understanding the whole person and helping them with the things that they needed from an equity. They were addressing by and large, 85% of the time, the social and behavioral determinants of health, which were really driving those poor health outcomes and high costs. Have people seen this kind of picture before? So the idea that of those two children born 2 miles apart, think about what I shared with you about methylation. If we can begin to think about how we reduce that gap, I think that's a huge opportunity. And it's how we begin to do that can feel a little bit overwhelming. How many of you feel a little overwhelmed by that? It's a little overwhelming. I felt a little overwhelmed. In fact, I felt overwhelmed for like a whole year. So you guys have only had a few minutes as you've been hearing this. You're doing great. Here, the solutions actually came from the people that we were talking with themselves. So the thing that they did in Guyana is they didn't try to come up with the solutions. They asked the people who were affected, what do you think your solutions might be? And then they put their heads together with them. And one of our patients drew this picture. She said, I have a child with a special health care need. And he was right in the center. His name is Gabe. And she's given me permission to share her story. And this is our family. And here on the left-hand side, this is on the bottom, blue, see that all the circles in blue? Those are all the people in the healthcare system that are interacting to help our child thrive. And that one of those bubbles is that primary care system, and I'm so happy that we're helping to make that primary care system better. But just so you get it, this is the rest of just our healthcare system. But if you're asking me what the health system is, look up in the top left, that's a school. All of the people in red, those are people through IEPs and special ed and physical therapy and occupational therapy that are involved in. I'd love once a year for my pediatrician and my teacher and their teams, the healthcare team and the school team, to talk with one another. But what people never realize is all these things on the right-hand side that are part of our sustainability as a family. And that red over to the right, that's our legal and financial team. I've had to quit my job to manage all this because there's nobody else who's managing it. So because I've had to quit my job, we have to think legally and financially how we'll survive. And what keeps me awake at night is that when I'm no longer here, no one will be able to do this. And all of that support system and that green, that's all of the people who help us to make it. It's our parents, our family, our neighbors. Nobody ever asks them what their insights are about what might be needed. And when I first saw this, I was like, that's a lot of people. The average Medicaid recipient has 5 care coordinators to often 11 to 12. We have a ton of resources out in the field, but we create cacophony for our patients, for our people, for the community members. And our opportunity is to go from thinking of ourselves in a poverty mindset to thinking of ourselves as an abundant community of solutions that has the potential to realize what it looks like when we actually connect the dots across this. Because the moment that I began going from thinking, this is just a lot for me to coordinate, for us to figure out how to coordinate, and went to thinking, look at all these people who are out there trying to do good for this kid. What would happen if we actually connected the dots and got together? It totally changed what we realized was possible. And we realized that for people who are in the community that I am a primary care doctor in, where 1 in 5 people are addicted to a substance and 76% of prisoners are rearrested, I shared with you the cost of where there's a school to prison pipeline. I shared with you the cost of chronic disease for diabetes from $300 billion to $500 billion. Well, frankly, spending $24,000 to $42,000 a year for essentially the rest of someone's life, where there's a 76% rearrest rate, means that we are spending the equivalent of a college education for the rest of someone's life instead of just sending them to college. For just 4 years, maybe 5 if they're doing well, But still, seems like a bargain to me. And I think our ability to reframe our health journey in recognizing that health, well-being, and equity are connected is huge. And our ability to see that health is just a contributor to life, for people to be able to live their own life, to recognize the interconnectedness between the individual and family. And you need to see and understand who those are, the community and the place that people are growing up in and society. I think we need to figure out how to connect these dots, how to be able to connect our mindsets and to work together to do this. And to see that, of course, health is happening out in the world where people really live. 100 Million is all about that. It's bringing together hundreds of people, organizations, and systems that have, maybe each of them has figured out a part of it. Most importantly, they just want to be part of learning how to create this other kind of journey. And it's an invitation for us to change our culture and mindset, to fundamentally transform the way we think and act, to create health, well-being, and equity. And we say that through unprecedented collaboration, innovative improvement, and system transformation, we can begin to get there. But we need to play at all 3 of those levels together. So there's 6 core strategies. Developing healthy, equitable communities, creating bridges between healthcare, community, public health, social sector, creating a healthcare system that's good at health and good at care, scaling up peer-to-peer supports, recognizing that people with lived experience, just like those community health workers, villagers, and teachers had great ideas. Actually, people know a lot about what's needed and actually listen to each other more than they listen to professionals anyway. Developing new culture and mindsets and creating enabling conditions, whether it's the data, the financing, other things that are needed so that people can actually focus on mission and not let the margin drive the mission or the need for a margin. And our overall framework is on health and well-being, equity, and sustainability. I'm sharing all of this with you to share some ways in which people are figuring out how to go on this journey, that there are communities all over the country, and just as you are doing in your communities, that are saying, how can we learn together? How can we see ourselves as this connected set of assets where we can share ideas about what works and figure out how to be strong together, how to have something that someone's figured out over here get all the way over there very, very fast so that we don't have to reinvent the wheel. You know, we used to say what we don't want to do is be terminally unique. Like everybody says, a community is a community. That's true, but we don't have to be terminally unique in our work and community. We can learn from one another. And every single success that I know of, including certainly ours, including what they did in Guyana, there were like a whole lot of things that they did that didn't work before they figured out the thing that worked, right? Do you really want to go through all those things that didn't work? Wouldn't you like to know those stories? But to know those stories, we have to have trust, right? Because we have to not judge each other based on our failures. We have to judge each other for having the courage to go on a journey where we do let ourselves try things, fail, and rapidly change direction, and to learn from one another's failures as much as we learn from one another's successes. And to do that, we need to create relationships and marry that to process and results. And so we've broken that down into these 4 core components. We say that the transformation of leading from within, of leading together, leading for outcomes, and leading for equity. And I'll just give you a snapshot of what some questions are that we ask ourselves in order to do that. We say, whose lives will get better because we were here? How can we partner with each other and with people with lived experience in a way that builds a community of solutions? Who isn't thriving in terms of their health and well-being? What would it take for that to change? What can we do to facilitate real transformation in health and well-being of people, systems, and communities? And how can we change the system? We've learned that asking generative questions, figuring them out together, spending no more than 3 meetings talking about it before trying something in the real world with real people is a really good way of approaching this. I don't mean you shouldn't plan also. You should. And the best laid plans fall apart often the minute you're out in the real world. And so have your plan be an evolving, developing one so that you can flexibly change it as you need to, and you haven't invested so much time and effort getting to it that it's hard to change direction.